for today's session, which again is the assault on the brain. And we are going to talk about understanding the impacts of Alzheimer's and Parkinson's diseases among African Americans, and what do we really need to do about it? What can we do about these two incurable diseases? And so I am Pamela Price. I'm the Deputy Director here at the Balm and Gilead. I also serve as the Director for our Brain Health Center for African Americans. But I cannot and would never dare to take on such a task of breaking down some of these diseases, and specifically what we want the African American community to know, by myself. And so I am definitely pleased and honored to have some extremely knowledgeable subject matter experts in this space to join me for today's discussion. So first, I want to introduce to everyone Dr. Ima Ebong, and I hope I'm saying your names correctly and not butchering them too much. She is an assistant professor of neurology at the University of Kentucky. She works there. She has clinical interest in general neurology, in focal epilepsy, as well as generalized epilepsy, and really just a very, in terms of her background and where she spends her time, she does work with the American Academy of Neurology. She was selected to participate in their diversity leadership program, which we know is so important that we work on increasing that diversity, both in leadership, but as well as in academia. She actually is in a clinic now, so we are excited that she was able to step out even for a brief time to join us for our discussion today. And we also just make sure that the full bios of all of our presenters are also available on the website. So please make sure that you go and you take some time to learn about all of the credentials and amazing work that today's presenters have been involved in. And then next we have Dr. Richard D. King. He is the Associate Professor of Neurology at the University of Kentucky. He's a board certified neurologist, and he has specialty training in cognitive disorders, in neuroimaging, and in clinical trials, as well as computational neuroscience. I am always fascinated, again, to see folks that look like us in these spaces of neuroscience. And so, Dr. King, we are extremely honored to have you, and looking forward to hear about more of your work in mentoring residents and students and graduate students, again, as we definitely need to make sure we are increasing this pipeline to have more people in this space who can address these significant issues in more minority and underserved communities. So thank you, Dr. King, for joining us. And then last, but definitely certainly not least, is Stephanie Monroe. Stephanie Monroe is a family. We have been blessed and fortunate to work with Stephanie, who is the executive director of the African Americans Against Alzheimer's, which is a network of the larger Us Against Alzheimer's group, who from the inception of our Brain Health Center has been an amazing partner with us in terms of raising awareness, disseminating information and education, definitely in the space of caregivers and what we need to be doing to better support, again, minority communities. And so, as we go on with the discussion here, I want us to just to keep in mind the theme of this conference really is the Black Health Agenda, and it's for this new decade, which is why Healthy Churches has made the transition to Healthy Churches 2030. Because we want to, we recognize that this work that's needed is not going to happen overnight, but we want to make sure that for this next decade, for this new decade, that we really are understanding these intersections of race, religion, health, and politics, as all four of these things have significant impacts on the health and well-being of all those that we are working to serve. So just again, keep that in mind as we go throughout today's presentation. So really briefly here, for those that may not be familiar, so the Balm and Gilead, our mission here has been able to prevent diseases and to improve the health status of people of the African diaspora. All this week, we actually have brought in leaders and partners of the Balm and Gilead from across the globe, because it is, we're not a monolithic population. It's important to understand what may be affecting us here. It may look differently abroad, and vice versa. but we do understand that by supporting faith in those institutions in things such as program design, evaluation, implementation of these faith-based programs, that we can do that and really work to eliminate health disparities. So in terms of the National Brain Health Center for African Americans, which again, we launched the center 5 years ago. And so the center really works to raise awareness of issues that are affecting the cognitive health of African Americans. We do this via capacity development of African American congregations so that they can become an integral partner. We provide a lot of training and information also to the healthcare and public health professionals regarding these issues and kind of how they are presenting in African American and minority communities. And we definitely work to make sure that we are creating culturally tailored faith-based tools and resources that, again, can help our congregational health ministries raise awareness, but then also support caregivers, also leveraging that power and influence that we know our faith communities have to shape things such as policy and local initiatives that really are meant to serve those congregations as well as the surrounding communities. So cognitive health. So why is it so important that we talk more about brain health, about cognitive health? And really, it's because it encompasses so much of not just our emotional, functioning, but it's how we think, how we reason, how we remember. It's such a, sometimes the brain can be I wouldn't say a forgotten, organ, but we focus a lot on heart health. We focus a lot on, other chronic diseases. And sometimes we forget to lift up, again, how even these other chronic diseases can affect our overall cognitive and brain health. That our brain health is something that we must work to protect across the lifespan. So cognitive health isn't something that we should be focused on and thinking about just as we age, but it's something that, in young adulthood, that we should be thinking about what do we need to do to protect it? What do we need to do to keep it intact? Because one of the things that we want to break in terms of normal aging and really letting people understand what that looks like. So even as we age, our intelligence should remain intact. We should still continue to perform normally on mental status examinations that we get with our healthcare providers. You can have some occasional complaints of memory loss. I think we all have those, maybe senior moments as we call them, and that memory loss, can be experienced by healthy people at any age. And that's what we want to kind of break down some of that stigma, is that, things such as dementia, as Alzheimer's, Parkinsons, these kind of cognitive brain health diseases, they are not just something that older adults should be thinking about. Because dementia is not a normal part of aging. We hear it time and time again, especially in the African American community and other minorities who just assume that as grandma ages, we ourselves just age, that senility is going to just become something that we should expect if we live long enough. And we have to break down that misinformation and tear down those myths, because that is not the case. But what we do know, again, dementia is a progressive decline, and it's not just in our memory. It's actually all of our cognitive function that impact us and interfere with us being able just to do, daily activities such as brushing our teeth, feeding ourselves, those types of things, especially as these diseases progress. So they affect our language, our problem solving, our judgment and decision making. And then again, it occurs due to damaged or disturbed nerve cells that, again, they support our cognitive function. And these can be by disease, by illness, as well as by injury. So specifically, we wanted to take a minute to look at Alzheimer's and Parkinson's disease. So both of these brain health diseases, these represent the two most common forms of dementia. And you'll see from that little funnel there, dementia really is an umbrella term because there are different types of dementia. But Alzheimer's and Parkinson's is the most prevalent and the most common type, followed by things such as vascular dementia as well. And so both, again, are progressive, they are degenerative, and they are irreversible. which means that as we have individuals who are diagnosed and living with these diseases, they're going to progress. And right now, we don't have anything that can restore cognitive function as it deteriorates. Even with things such as Parkinson's, that definitely has some neuromuscular effects as well, trying to, reverse the symptoms that are associated with those. We just don't have the therapies to where we would need them and definitely would want them to be, which we're going to definitely touch on and what we need in terms of research and trials for both of these diseases. And then we also know in terms of Alzheimer's disease related brain changes, these can occur 15 to 20 years prior to this onset of symptoms, which again, that can impede our ability to diagnose individuals earlier, which is a major problem and concern. So the earlier that we can recognize those symptoms, the better. And then in terms of Alzheimer's disease death, we know that it increased by 146% between 2000 and 2018. Sadly, we don't have some of the research that we really need when it comes to Parkinson's disease to be able to kind of split out some of the risk factors associated with Parkinson's disease, as well as, again, effectively being able to monitor data related to deaths. A lot of that, it has to do with whether or not it's even listed on death certificates of individuals who have passed away. So that's an area we definitely have to do better about, making sure that we have the best data that we can, so that we can truly have a sense of prevalence and incidence, as well as how can we use the data to combat both of these diseases. And so we definitely have a long way to go in terms of both of these brain health diseases, so that we can begin to, again, develop more community-based programs and approaches to helping loved ones impacted by them. And then in terms of Parkinson's disease, we do know that the death rates are higher among African Americans. And this is despite the current data that's available in terms of prevalence and incidence that actually mostly suggest that you actually have more non-Black or more white individuals who are living with Parkinson's. But again, that data is not the most reliable because we haven't done our due diligence in terms of making sure that we get more minorities into these studies so that we can actually see who has what. Even our systems and data in our Medicaid services that serves an older population doesn't quite get us to where we need to be in terms of the data aspects. But nonetheless, like many other conditions, we do know that African Americans are disproportionately impacted by them. So in terms of some of the signs that we may see of someone developing dementia, so we know that it's memory loss, again, that disrupts our daily life. We have challenges in planning, challenges and difficulty with just things that are familiar to us. Can become confused with both time and or place. Trouble understanding such visual images, our spatial relationships. That's why you have the issues with falling as the disease progresses, as well as misplacing things, can't retrace our steps. And then one of the ones that definitely has a significant impact on caregivers is the fact that there's a withdrawal both from work as well as social activities. And so not just the individual diagnosed with dementia, but also that caregiver and that family are significantly impacted by withdrawal, which really limits our caregivers and affects their mental health as well, which is why we also want to make sure that we are acknowledging the role that our caregivers play and how we better can support them.
One question here. So we're getting a lot of questions already in the chat, and they're great questions. I want to make sure I answer them, but they can get lost in the chat if we're not careful. So can we have everybody make sure that they're putting questions in the actual question and answer section so that I can make sure that we actually get to all of them as opposed to the chat?
Absolutely. So if we could make sure that, yes, again, if we do that, so there's a Q&A button that everyone should be able to see. And if you do it there, they actually go to a queue, and that is being monitored. The chat kind of is, the more you put things into that chat, it goes up, and you can definitely, with scrolling, can definitely miss anything. So thank you so much for bringing that to our attention. And as I mentioned, if there are any questions, again, that do come through either in the chat or in the Q&A that we are unable to get to today, please make sure that you, again, stop by our booth. Those questions can be entered into there, as we will have chats available through the virtual brain health exhibit booth as well. And same thing, these slides will be on there as well. I definitely want to go ahead and get to our presenters today. So these are, again, just a few more reasons as to why we are having this conversation. And as I mentioned, sadly, we don't have all of these measures and metrics when it comes to Parkinson's disease, such as how chronic diseases, how other genetic factors may come into play with Parkinson's. So the research has definitely gotten a little further with Alzheimer's, but we know it's the 5th leading cause of death for older African Americans. The risk for developing it is 2 to 3 times higher for African Americans. Same thing, we are still needing some more data to see what risk of developing Parkinson's occurs, and what is that rate of risk in terms of African Americans, and then knowing that the role that other chronic diseases and comorbidities play in terms of increasing our risk for dementia. And we do know, in terms of just dementia as a whole, having things such as high cholesterol, as diabetes, as high blood pressure and heart disease, you're looking at a 4 times greater risk or chance of becoming or developing dementia just by those. And I think we all know that African Americans suffer but we are impacted disproportionately by these chronic health conditions. So when we look at some of our challenges, we know that, as I mentioned, there is no cure. Available medications, non-drug options, they may work to help slow and or treat symptoms of these diseases, and many factors can impact African Americans getting diagnosed in a timely fashion, as well as us accessing and utilizing available care and services. And then the overall quality of life once we are diagnosed as African American significantly differs from that of whites, because the stage is usually later. The disease has progressed relatively further in terms of stage, and also, again, the access and utilization to the care that we need also significantly impacts our loved ones, typically dying quicker, and definitely experiencing a much poorer quality of life. So those are all the things as our challenges that we want to think of. So really, we want to go ahead and bring in our panel discussion. And we want to talk about the challenges, again, of early diagnosis and treatment. We want to talk about research and clinical studies. As I mentioned, that's an area that we definitely have to do better. Caregiving specifically, and what these needs are and what we can do to support our caregivers. And really, what is the role of our faith leaders and the community together, including public health? What is the role, and what is it that we need these two communities to come together to do, so that we can begin to turn the tide in terms of addressing both of these brain health conditions? So with that being said, I'm actually going to come out of our slide now and take the screen share off and bring in our amazing panelists, as I mentioned. So it's nice to see faces when you've got the slides up, can't really see everybody's faces. So I just want to thank all of our presenters again for joining us, and we're going to hop right to it. And so the first question I have is actually for Dr. Ebong. And so you, as I mentioned, are a clinician, you're in clinic as we speak. And so what have been some of the challenges that you've seen regarding the adequate diagnosis and treatment of Alzheimer's or dementia, or just kind of other brain health diseases? I know you also do a lot of work with epilepsy, which is also a focus of our Brain Health Center.
Yes, one of the challenges that I've been seeing, especially among my African American and Black patients, is trust in the medical system. And in order to tackle that, we have to really go back and look at our history as physicians in this country, as medical practitioners, and the unfortunate experimentation that was done on Black people from the time of slavery, even up until the last century. And one can argue even more recently, especially in people of color, as you can one thing that comes to mind, not in neurology, but recently in the news, as you know, in Georgia, there was some concern about women who were in the ICE detention centers having their uteruses taken out without their consent. So we have this dark history where there isn't any trust. And I've been doing a lot of reading and research on this topic because I always wonder, I do have a lot of African American patients who would come to me and they would ask questions like if I were to send them for a routine EEG, oh, are you treating me like a guinea pig? And one asked me that last week and I felt horribly because one, as a Black woman, I don't want my Black patients to ever think that I will treat them differently from any other patient. But two, it goes back to the mistrust in our field. And I think once we all address that and we all say to ourselves and to our patients, like, hey, we are here for you, then we can go over, get over that hump in our history and begin to really, really get to the root of these diseases in our communities. I think you had said something that is really pertinent, that these diseases transcend race, they transcend ethnic groups, they transcend cultural backgrounds. Alzheimer's is a disease of all populations. It's not specific to African Americans. So why is it that our rates are higher, our mortality and morbidity might be higher? And it's not because of our race. It's clearly racism and the history that we have in this country. Why aren't we getting our families and friends into the doctors quicker? Is it, again, the mistrust? Or if they are going to the doctors, are they being misdiagnosed? We do have a high rate of misdiagnosis in our community. Sometimes people think that we are faking our symptoms, and just those things. So we do have to come to terms with our past. There's another thing that I want to touch on too, that Alzheimer's, one of the key risk factors for Alzheimer's, as you alluded to, is age. And in the African American community, between 1995 and 2030, the the number of African Americans age 65 and up is going to more than double. So definitely, we need to make sure that we take care of ourselves and our elderly friends and family because the numbers are there. On the flip side, as neurologists, and Dr. King could allude to this, our numbers aren't increasing that much. Neurology remains one of the least popular fields in medicine. Our numbers are small. We're not able to take care of all the aging population. And not only all neurologists, but African American neurologists, we make up less than 3% of all neurologists in the entire country. So you have two of us here at UK, but we're still not able to meet our population's needs. There needs to be more of us in the field as well. And you had mentioned some of my background in the diversity leadership program, but that's what I want to do. I want to encourage the next generation of doctors to pick our field, especially doctors from underrepresented groups such as ours.
Wow, it's a lot to like unpack in everything that you said, but I think the biggest takeaway, and I hope that the participants heard, is trust. I think that's going to come up a lot. I think that will come up throughout this week because there is not just the reckoning that we're seeing in terms of the social unrest. This has long been, as you mentioned, a part of medical of healthcare. And if you think about how critical of all the sectors and things that touch our daily lives, how critical the healthcare system is. And when we lack the trust to access it, when, like you said, even as Black, a Black clinician, and you're getting the question, are you treating me as a guinea pig? It lets us know we've got a lot of work that still needs to be done. And again, I am always thrilled to see our Black and Brown people in these fields that we definitely need more of, and just applaud you and Dr. King for your work again. And Dr. King, I'll actually kind of come to you because again, you are a board certified neurologist. I don't think we have, I don't think we have many of those, as Dr. Ebong mentioned, and I would even go further to say we probably don't have many that are African American. So that in and of itself is something, but can you share with us, again, you do things such as neuroimaging and the biomarkers, because I think that has come through a little bit on our chat. So can you explain kind of what are some of the biomarkers that as a clinician that you have to kind of educate your patients on and educate the community about, and what is available, and that it's not new perhaps. So it's not that we're trying to test out these new diagnosis options, but they've been there, and perhaps again we just haven't done our job to get them, you know, into the communities maybe that need them. So can you share with us a little bit about your work with the neuroimaging and
absolutely. So
biomarkers?
there are about 5 answers to the things that you just said. So let me try to unpack this a little bit step by step. So the first question that I always get every week in clinic, and I am a clinician, I do see patients in my clinic. So yes, I am trained to do that. Everybody asks, what's the difference between Alzheimer's disease and dementia? And this is tough because the definitions of these things are somewhat changing as we've learned more about them. And the other problem is that people use these words sometimes in imprecise ways. So let me define these terms for us so that we can all go forward on the same page. So dementia is not really a diagnosis. Dementia is a clinical description. It is a description of a person's symptoms. It says that a person generally has memory loss, at least one other area of cognition involved, and it's enough to impair daily function, but it doesn't say why. It doesn't say how severe, right? So it's kind of like saying I have a headache, but is it because I have a migraine or because I have a brain tumor, right? So there can be lots of reasons for the same presentation. So there can be a number of causes for a clinical dementia syndrome. Some of them are reversible. So these are things like maybe depression or sleep apnea or nutritional difficulties that can lead to problems with cognition. Many of those, if they're identified, can be treated and those can get better. There are other types of diseases like, say, a stroke syndrome where there's been an acute change and there's been brain damage. And so I don't have a great way of fixing the damage that's already been done. But if we work together, we can prevent this from getting worse or from happening again. So those are diseases where there is a change, but we would expect people to stay generally steady, maybe improve a little bit, but they shouldn't be getting worse as long as we're able to treat the underlying risk factors. And then there's this third category, and these are diseases that are slowly progressive, that we don't have a way at the moment of actually stopping the progression. We can do things to help manage them. We can do things to help you to function better, but I don't have a way of stopping it from proceeding. So diseases like Alzheimer's disease fall into this category. So natural history is a slow, steady progression. And these are things that despite heroic effort, medical science has not yet developed a cure. We don't have a way to stop this. Okay. So a lot of what I do in my clinic, so the first thing I try to do is to make a diagnosis, because it's actually not that easy. I have to answer the question of what's going on, what's the reason it's going on, then what are we going to do about it? And we need better tools in that process. So that's what a biomarker is for. So a biomarker can come in many different flavors, whether it's a blood biomarker or an imaging biomarker or some kind of screening biomarker. It is something that we can do quickly that will give us information about the patient that allows us to predict their outcome better or to manage them better. So much of what I have been doing for my research is involving imaging biomarkers. It's trying to get a picture of your brain and saying, how can I use this picture to better understand where you are, where you're going, and then to see whether we can make interventions that actually work to prevent those changes. Not here. So in terms of biomarkers that are available, so just understanding how research works is that there are studies that we do as scientists, as clinician scientists, that say, I have an intervention that I believe can be helpful. That's my hypothesis, okay? We have to test that hypothesis to make sure that it actually works the way that we think it does. So this involves a clinical trial. So a good clinical trial to answer the question of, does this new intervention work? The intervention could be anything from a new drug to a behavioral modification, to an exercise program. There's any number of things, but to answer the question, does my intervention work? I need a randomized, placebo-controlled, prospective trial. And those are the big words that go into those. Each of those words adds complexity, but it enables us to do actual science, is to say, did this thing actually work? The process is a little bit slow, but it's designed that way because if you don't take the time to actually watch your intervention and then watch for side effects after your intervention, you don't really know if it worked or not. And the last thing that you want is to have an intervention that we think worked that actually doesn't. And so people try to jump the gun on that a lot. And you'll see you'll see some drug companies, for example, that will try to market their over-the-counter medication as a therapy. But on the bottom of the bottle, it says not intended to diagnose, treat, or cure any condition, right? So if you see that on the bottle, it means that your bottle there has not been tested properly to actually warrant an indication. So in order to get that indication, you have to go through the process, and it's difficult, and that's why we do this. And the problem is that if we don't get volunteers from the African-American community, then we don't know if these trials that we're doing actually work for us, right? So many of these studies were done on like 20 and 30-year-old Caucasian males because that's who's available and that's who volunteers for the studies. And that's great. It answers a lot of questions, but it's hard to extrapolate from 20-year-old African-American male to 80 and 90-year-old African-American male and female, because there's differences in the population. So you have to test the people that you actually want to treat if you want to know if these interventions work. So we have to be involved in clinical trials if we want to know if these things work for us.
Absolutely.
Yeah, there's a lot more to that, but I'll stop for a second so that we can digest that. And
no, I appreciate one again the breakdown of what you said, and again just making sure that we are aware of what we're talking about. Are we using the right words to communicate the difference between a disease, as opposed to a symptom of a disease, or the way that you're characterizing something that is happening in our brains, and how that kind of tracks to whether or not we can appropriately diagnose it, and then whether or not we can treat it appropriately. And definitely everything that you mentioned about the trials and about interventions and knowing whether or not something works, we have to, like you said, do the work. We see commercials for things like Prevagen and other, like you said, over-the-counter things you can pick up at your local CVS. But like you said, there's that nice disclaimer, because as opposed to them doing it the way you recommended, they obviously did not. And so now again, they're putting, something out to market that, like you said, we really don't know if that's effective. And could it be something that we could use to better help slow progression or help save what memory capacities that we have. And so thank you. I think, all of those points that we're definitely going to come back to the whole conversation around research and clinical trials, because that is, we will never address not just Alzheimer's or dementia or Parkinson's. We will never address any of these health issues facing African-American and minority communities if we don't change that dynamic. Regardless of, drugs coming to market, therapies coming to market, but as you mentioned, interventions, behavioral interventions, we can't do those things again if the folks who we want to create these initiatives or interventions for, we aren't able to get them to answer the questions that we have. Stephanie, again, you definitely, based on your work that I know in the Alzheimer's space, your center, the work there with the different networks of Us Against Alzheimer's, you are trying to lift up a light on what are some of the things we can do from a preventive kind of maybe risk reduction standpoint. So before maybe they need a Dr. King or they need, a Dr. Ebong, when maybe it's just they're interacting with their primary care provider who doesn't have this specialty. What are some things that you can share with us on where we are with some of that with some of those efforts, and where we, maybe need to even do a little bit better in terms of how we're communicating what we can do, again, maybe from a behavioral change standpoint.
Absolutely. Thanks so much again for including me in this conversation. I think for us, one of the challenges has been when we started doing our work in the communities was before we could present options and action that could be taken, we had to convince people that there really was a problem. And if there was a problem that we could actually discuss without shame, without labeling it something that it wasn't. I've often heard people call it sometimers. Sometimes they remember, sometimes they don't. Downplaying it, putting little uncle in a separate room when you're having a family event, anything but label it or seek medical help because it's something we don't understand, or we feel that it's, we're out of our right mind, right? We view it as a mental health condition that can't be treated. So our first effort really is to give people permission to talk about it, let them know that the symptoms that they're seeing, in fact, are not normal, and that there might be help for them. First, we got to talk to people about their brain itself. As you said earlier, people don't usually sit around thinking about their brain. Yet, in fact, it's the most important organ in our body. It tells our lungs to breathe. It allows our hearts to beat. It tells us how to walk, talk, think, swallow. And when our brain is impacted through Alzheimer's or other types of dementia, those are the things that go away, which eventually lead to people having to get 24-hour care. The good news is, and I tell folks, is that cognitive decline is not inevitable. We all hear about the 80, 90, 95-year-old person who was a Jeopardy champion, who is running these marathons and just exceptionally performing, when in fact, that's how we were intended to perform. These people are not living abnormally. They are what our bodies was intended to perform. And we just have to work hard to try to put ourselves in the best position to perform to our own individualized maximum. We found in the US, and it's a little bit that when the United States makes a decision that they're going to tackle a problem and they put the resources and their brains behind it, they've succeeded at doing this. And so when we look at things like heart disease and cancer, the top 10 causes of death, all of those diseases, those numbers have decreased, except for Alzheimer's, which has increased by about 75%. And so one of the things that we have done as an organization is to challenge, we've worked the last 10 years with our partners like the MOM and others, to tell Congress, this is unacceptable. We need you guys to figure out what this disease is, how we're going to tackle it, give us the appropriate resources in communities, not equitable resources, because to achieve equality, some communities that are over impacted need more than others. And we need to be really holistic in terms of what our approach will be to this. And so we've worked there. When we started, we were at about $400 million of investment in the federal government, and we're now over $2 billion. So we're getting the resources out there, we're seeing progress. And so therefore we're learning more about it. And one of the things that we are learning is that, there are things that we can do, not necessarily to stop Alzheimer's, but certainly to put us in a better position. We have an ability now, we believe, to reduce dementia risk, to slow the rate of cognitive decline as people age through early detection and non-pharmacological, as well as pharmacological interventions across the lifespan. Alzheimer's doesn't just start when you hit 80, right? We see declines starting from a very early time. In fact, we know that preschool interventions are really important to set the brain up to be able to maximize its potential. So we know that there are certain things that have worked for the heart that actually help with the brain too. We need more research to show us what the timing is, what the intensity is, how to really deliver these quote unquote healthy prescriptions to people. So for example, healthy nutrition. As one doctor said, putting a lot of color on your plate. It's not what the particular diet, it's making sure that you're getting healthy fruits, vegetables, green leaves, fatty free if you can, protein, lean proteins, fish, all of those things, but to diversify your plate so that it looks colorful. Yeah. Our family would typically have for Thanksgiving dinner, brown meat covered with gravy, maybe a little orange on the side with tons of sugar on it and some greens that had been baked. Yeah. right? That's what we would have. Okay, it's an indulgence for that one period, but if that's your diet routinely, probably not the best, most healthy thing for your heart. Education, keeping not just engaged with your brain, but the lifetime of learning. The best thing that we can do for our brains is to keep our brains guessing what's coming next. And so it's never too old to learn a new language. I just learned how to play puzzles, I'm embarrassed to say. And I actually found, I didn't think I could do them, but I can actually do them. And it's stimulating to my brain to have to do something new. Making sure that we're treated for conditions that we have, especially vascular conditions like diabetes and hypertension, because keeping those under control appears to have a link to keeping or preventing us going into a cognitive decline. And of course, healthy and appropriate and modified exercise, social engagement, not smoking, treating and identifying hearing loss, treating and identifying depression, anxiety, obesity. This is a package. So it really is about setting yourself up for success in terms of aging, and that will set you up for a greater likelihood of being able to do your best to prevent cognitive decline.
Amazing. I mean, there's so many things again that you pointed out, and you may not be able to do all of them at the same time, right. But it's encouraging, hopefully for attendees to hear that there is something again that we can do, and like you said, and really look at this from a healthy aging. We know that again, in terms of some of these diseases that we can't pinpoint that, if you do X, Y, and Z and guarantee that, hey, look, you're never going to get, Alzheimer's, or you'll never get Parkinson's. But as you said, but we can do what we can based on the science and data that we have now to say, well, if I at least do these things, I'm not helping, or I'm helping myself, do whatever I can that's in my control. Because
we've got to go to the gym, right? We've got to pay money. Right. You don't have to. When I was talking to my mom is 87, and we're trying to get her mobile, right? And she said, well, I can't go downstairs to I can't go to the YM. And I'm like, Mom, you can practice sitting in a chair and standing up without touching something. That creates balance. That prevents falls. Yeah. You can, instead of having weights, you don't have to go out and buy weights. You've got cans of food. You can do things by just lifting cans of food. So just using your environment, there are things that we can do to help ourselves, and working together as a group. Yeah. I know we can't do it as much together now as we would like to do it, but there are just some of those things that can help, and I think are very empowering to people who feel that, why would I want to find out about a disease if I know there's not a cure for it right now? Well, because there are things that you can do for yourself.
Absolutely. You said it, because I think people can hear that we don't have anything right now in terms of treatments or cures. And so, well, why do I need to even be paying attention to it, especially if it's something I'm not impacted by? So that's so important.
Let me clarify that just a little bit before you move on there. So in terms of treatments on there, so yes, there are no medications that can stop the disease from progressing. There are 4 medications that are FDA approved for treating the disease that can help with symptoms. So medications like Namenda or Memantine or Aricept, which is donepezil, is a generic name for it. So these are medications that can improve performance on clinical tests. So for example, if you did a 30-point cognitive test on somebody who has Alzheimer's and you gave them the medication and did it again, you might see a 3 or 4 point change. So it's not dramatic, but it does make a difference. It's measurable, and it helps in caregiving. So I do recommend using the medications and keeping people on the medications, but just keep in mind that the benefits are going to be subtle. And so as long as you have the right expectations for them, they're helpful things to include. So,
absolutely. And two, as we think about that, and you brought up, because as clinicians, you're prescribing, you are, encouraging individuals to take an opportunity or take advantage of what we do have, at our disposal right now. So to Dr. King and both to Dr. Ebong, how do you work knowing that we maybe don't have certain trials where we need them to be in terms of newer treatments and therapies? How do you work to make sure that minorities maybe feel safe, that they can kind of overcome that mistrust to actually want to have their loved ones take the medications, like you said, knowing that what they may see will be subtle, may not be exactly what they were hoping for, but to encouraging them to at least take advantage of what we do have available, because that is a challenge that we face, is that for even with what we do have, we can't get enough of our loved ones and our families to even want to take advantage of these therapies and treatments.
So for me in general, what I make sure I do, and I do this with all patients, regardless of race, I always print out everything in language that they can understand and that their caregivers can understand. I think a lot of the reasons why some patients, especially African American patients, might be apprehensive of drug trials or drugs or medications is because that they don't get a clear understanding of the disease or the treatment. Just think about, any of you on the line can think about going to the doctor. How often, in this day and age with electronic medical record, doctors always seem rushed. They have a packed clinic. How often are they really sitting there talking to you, printing out, that sort of thing? And even me as a patient, because I am a patient, I've been to doctors, and sometimes they assume because I'm a physician that I understand. If it's something that's outside of my realm, I don't. But I know I can always go and look it up myself. Everyone's not going to do that. So I make sure I do have, regarding epilepsy and neuromuscular diseases that I treat regularly because that's my field, I have printouts already made that explain my most common diagnosis in simplest form. Any of the clinical trials that we have available here at UK, in terms of epilepsy and neuromuscular, again, because that's what I do, I make sure that I give that opportunity to all my patients, regardless of race. And unfortunately, I still run into the roadblock where I don't get a lot of African Americans in the clinical trials that I'm involved in, even though I do present them with the literature and present them with like what Dr. King said, how important it is for our people to be in the trials, because the trials are usually done on people who don't look like us, on younger white males or older white women. Again, they're not our population. And it's a start. I think it's not a full answer, but it's the start to make sure you just educate your patients. And I don't give up. So I the next time they come to clinic, I revisit the trials, revisit any new medications that might be on market, go over the risk and benefits in detail. And if they say no, the next visit, I just keep going. I keep pushing it. And I know one day they're probably going to say, okay, maybe she knows what she's talking about. And that's another thing. Sometimes physicians do maybe give up. They probably just present the idea once. And if the patient says no, they're like, well, that's it. I'm not like that. I'm going to keep pushing it if I think it's going to help the patient. But at the same time, I do respect patient autonomy. And if they say no, I'm not going to be like, well, if you don't do it, then you can't come back to my clinic.
Right. Penalizing it.
Great. Yeah. So I want to make about 3 really important points here so that everybody can take this home with them. So the first one is that clinical trial research now is highly regulated. It's not able to be done just ad hoc or just with somebody's whim. Every single trial that is done goes through review through the Institutional Review Board. And that is not a simple process. It requires, well, the review board itself has both clinicians on it, but also members from the community. And we have to generate a document that gives you informed consent. So nothing can be done here without you having informed consent. And so what that means is that you get, as Dr. Ebong said, a document that describes any procedure. It describes what's going to happen, how often it happens, what the risks are, what the benefits are, and you often will get paid for research. It describes sort of the salary of the compensation that would be involved, and you get a chance to look that over before we do anything. And then once you've read it, had a chance to ask your questions, had all of your questions answered, then you can, if you agree to it, sign the consent form. And remember that consent is not blanket forever. You can withdraw your consent at any time. And you can walk away from a study at any time. There may be health consequences to that, but you'll be informed of those well before you start so that you know exactly what you're getting into, what the benefits are, and what the risks are on there. And so these documents go through intensive review and they have to be updated annually. There's a re-review process. And then for every study that involves a pharmaceutical agent, there is a data safety monitoring board that's external, that is watching this, that also does reviews about every 6 months to say, what's happened in this study so far? Have there been any significant side effects that indicate this might not be safe? Have there been such success that we should stop the trial early because now it's not ethical to not give this intervention? This intervention was so good, was proven to be helpful, that we need to go ahead and say yes. So we certainly hope to have great results like that. And there have been a number of studies where it was so clearly beneficial that you stopped the study early because they got approval. Unfortunately, many of the studies involving Alzheimer's disease, when you start the study, you have a clear endpoint that you're trying to reach. And despite good preliminary evidence at the end of the trial, they didn't reach that endpoint. So every time a study is done, even if it doesn't reach its successful endpoint, we still learn something. And we have learned a lot about Alzheimer's disease and how it works and what we need to do. And we are making progress. It's just that we haven't quite reached the point of having a new drug yet. We're getting closer. I don't know if any of you have been following the FDA and their recent review of the drug that's aducanumab. So a company named Biogen in Boston had this drug that when they did the big clinical trial of it, I was involved in that study, that when you look across the board at all of the dosing levels for that trial, it did not meet its endpoint. But when you looked at just the highest level of dosing, there was positive data. And so the company was trying to get approval just based on that subset of a study, and the FDA said that wasn't enough. And I think that's a reasonable decision, but it's also a hopeful bit of data because it says, oh, we saw a signal here. We need to understand that signal better and further clarify it. So we are making progress.
Yes. Yes, absolutely, which is so important because I think, yeah, and even to Dr. Ebong's point, I think we can't get complacent, and I also think we can't give up, whether that's sharing the information with our patients or sharing it with those in the community and those that we touch and continuing to share it. I think it's one of the things we learned from our marketing and communications team is how many times we have to put our message in front of one person to actually get them to hear it. And it's like, tens of thousands of times in terms of putting it, it's in their hands because I printed it out, and maybe they also saw something on social media, and then they also saw it again. In our case, they saw it again in a local Sunday morning health corner that the church printed, and so just however many ways, I think, to get the information that each of you have shared, even what you mentioned, Dr. King, I don't think we've done a good job of making sure that people know how safe our trials really are compared to what they used to be. And I think you probably have more experimentation, more challenges in maybe in the clinical space in terms of what and how care options are being discussed and what's being presented and how it's being presented. I think that's maybe where we have even more work to do, as opposed to have we done our job in making clinical trials safe. And then, maybe the next step is communicating how safe they are, and every point that someone from the community can engage with the study. So not just at the participant level, but can you volunteer to be on one of the review boards? Can you volunteer to partner with an academic institution who is participating in a trial to be that kind of liaison between the community? Which, Stephanie, I want to come to you a little bit, because I know we have seen more of a push to make sure that community engagement is something that's built and baked into clinical trials and research. And so can you share a little bit, just on the perspective of community engagement in this research framework, what that really means, and how should we really kind of be approaching community engagement, and not just yielding people to sign up, but are we really supporting that community?
Absolutely. This could be another whole 3-hour conversation, very short. Because I think that one important thing for people to remember is that, when we don't effectively engage communities, we're leaving communities out, which means we're limiting scientific knowledge. Most research decisions and medicines are approved with 97% participants being white males. And they assume impacts on Blacks, Latinos, and women. And that's shameful. If it were the reverse, which it will, as our communities grow, you have to wonder, if all this research will be done now on Black and Latinos, maybe women, will the other side be as accepting of those as outcomes, right? When we started in this space of community engagement, we were first told that Blacks wouldn't volunteer, like they just wouldn't do it because of Tuskegee. And we very quickly began to understand, by changing the messaging, changing the look of the messenger, and changing who we partner with in the communities who were already trusted, that about 80% of people, when you asked them if they were interested in research, would say yes. So dispel that myth. There was an intrinsic bias that was built in that said, don't even go there, because those people, if they sign up, they won't show up. And then they'll drop out. And they're going to be hard to maintain. There's a lot of handholding. They're going to be so much expensive, right? You got to, all this stuff. So we're not going to make the effort. They don't want to talk about that, but that's really what's happening. Or you filled your study, you're 97% full, and then you go, oops, we don't have any Blacks or Latinos. So now you got to run out and try to backfill with people that you had no relationship with ever. That people assume that you're known, you're a particular college on a hill, and that you're known because you're up on a hill. Well, you may have the zip code, but you are not in the neighborhood.
Yes.
And so you've got to be in the neighborhood. You've got to be offering, you've got to be present more than when you just want something. You have to ask the community what they want, how they want to receive it, and come together with them in planning how you're going to provide this lovely meal, this dish, these opportunities to the communities that shows that they really are a valued team member. And that's how you start. It's like planning a party. You don't just come in there and say, I've got something for you. If you're smart, you'll take it. No, it doesn't work that way. Especially don't think you're going to go to the church and meet with the pastor and tell him that he needs to give you entree into his congregation. No, it's not going to happen. So
not at all.
At all. Like that you might have ruined it for the whole community if you try to do that. And so changing the approach, and then building a platform that is ready to be eaten, right? So when we get people to say, yes, 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 we want to participate in research. And then they go and they ask a large hospital, can we participate? And they say, oh, well, are you married? Do you have health insurance? Do you have a study partner? Can you take off work once a week for free and come down here and get this done? Oh, and by the way, we're going to take a lumbar puncture. And, oh, do you have health insurance? Because there'll be fees that aren't going to be covered by what you are participating in. And, oh, we're not going to tell you whether they're getting the real medicine or not the medicine. Oh, and by the way, if you have diabetes,
can't do it.
All kinds of ways to exclude you instead of building a trial that can be scientifically rigorous, but also provide an opportunity for as many people who want to participate. So at Us Against Alzheimer's, we're working with that. We're working on how do we connect with the best and the most trusted, which we've, through a project grant that we've received through the CDC, we're forming a Center for Brain Health Equity. Because when we see these disparities, it means there's an inequity that's happening. We've got to figure out ways to get these numbers down, especially for the African American community. We are 13% of the population, yet the cost of Alzheimer's, we are bearing 33% of the cost. We have 13% of the population, but 20% of those who are actually diagnosed with Alzheimer's. So something's wrong here. So we need to, and a community, collaborate with the churches, the sororities, the fraternities, the links, the barbershops, wherever people are, that's where we need to go. And let them form as a community to advise healthcare providers, this is what we want, this is the message, these are the messengers. By the way, if you have no diversity on your staff, you might want to fix that before trying to come in. And just giving them kind suggestions about what it really takes to communicate effectively and to show yourself as being present. And then what are you going to give back to the community? Give us the information back. It doesn't have to be necessarily monetary, but let us know how we did when we've come in to participate. You know, let's plan the next event together. And by the way, we want to hear about Alzheimer's now, but maybe tomorrow we want to hear about sickle cell. Can you set that up for us? Right. You know, working with communities, one of the things we do is making sure that the messages are culturally tailored, that they're written at the appropriate reading level, that we get rid of big terms, amyloidosis and things like that. We can have those terms, but let's break it down so that people, as Dr. King did, in a way that they can have it. You're not communicating if somebody doesn't understand what you're saying. You know, if someone starts speaking French to me, I might understand a couple words, but basically I'm lost. So we need to make sure we're speaking a language that people can understand, and that we're delivering messages the way people want to receive them. So as you know, Pam, because we brought Forget Me Not Play to the BOM, we chose a platform. One of our platforms was to deliver it through a Tyler Perry style musical. And all the information was in there. We did a talk back session at the end. People were extremely enriched. We've had hundreds and hundreds of people come out for that to receive the information. We brought local people there who could talk about it. We had African-American clinical trials participants, a Black neurologist, people who were there in the community to connect them with caregiving services and things like that. We brought people in with booths to talk about different services that they provided, AARP and others. And it became a community event, and it was free. That's one, it's a tool. There's nothing magic about it. It's just figuring out that's something communities can view that's authentic to them and it's not threatening to them. And we were able to get them to the same place where and they were asking us what could they do, rather than us having to push it. So I love talking about this stuff, but you know, there's so many, but I think the most important thing is be intentional. If you're going to plan a trial, if you're going to partner with the community, be intentional. You can't partner with the community without including the community in your partnership.
Absolutely. A key word in everything that you just said was relationship.
Yeah.
Because I think that that can be missing and or lacking and not understanding, you know, like we try and explain to people, even when we're making the connection. So when the BOM is saying, hey, look, we want you to connect with these churches. We want you to work with these local health ministries and the College of Bishops and the Board of Bishops and all of these Episcopal coordinators who are doing work. They are touching the people that we all want to touch. But we let them know, even beyond a partnership, because you can walk away. A partnership can be quid pro quo. You give me this, I give you this. A relationship, maybe I didn't really get anything out of this, but to maybe get to know you. But this is everything that I am bringing to the table with you, because it's the relationship that I want more from you, as opposed to numbers, as opposed to turnout, as opposed to enrollment into something. And I think we really encourage people not to use same thing as we don't want people using dementia and Alzheimer's interchangeably, because they're not the same thing. We don't want you to misconstrue your partnership efforts with your actual relationship building efforts, because that's what you're hoping to build. I'm in a relationship with my husband, which means I'm probably not going to walk away because he forgot to take out the trash or he left his clothes somewhere. You know, if we had a partnership and that was in the contract to say, hey, you were supposed to do X, Y, and Z, I easily could say, well, you know what? I don't want to be in this partnership anymore. And so relationship is key. And as you said, to make sure that it is intentional. People want to see your authentic selves. And that does require that your organizations look like the communities that you are saying you want to serve. So I wish we had more time. I know eventually I'm going to start getting a cue. But before we open it up to the Q&A that I see is quite a bit in there. I've seen some chats that also have been coming through. I wanted to touch on definitely a key piece into all, and that's caregiving. I'm a sandwich generation caregiver, I guess, if that's what you want to call it. My husband has some cognitive decline. We've got small children, twins that are 6, a teenager, I work. So all these kind of different things, you know, combining. So caregiving is so important that, and I'm sure as clinicians, Dr. Ebong and Dr. King, when you are taking care of your patient, and I think you even said it, Dr. Ebong, that you pass on the information and literature and make sure that that caregiver is also a part of that conversation. So if I could ask, and I'll start with Dr. Ebong, but I really would love to get and hear from everyone. how you see caregivers in the work and spaces that you work in, and how you work to support them and make sure that they are included kind of at every step, and thinking about the ways in which we better support them. So again, I'll start with you, Dr. Ebon. Oh, you're muted. Sorry.
One of the things on my bio is that I not just take care of the patients, I take care of their families as well. And the role of the caregiver is very important. They're usually the closest to the patients. At times they're also the patient's next of kin in terms of being their not their legal sorry.
Kind of proxy.
Sorry, no, yeah, they're proxy. Sorry, my patient just came in, so I just got a notice. Sorry, that's trying to trip me up.
Okay.
So I'll answer this and then I'll leave. So yeah, they're proxy, and but you have to remember that being a caregiver, they're usually with the patient 24/7. And one thing I encourage is respite. So I make sure, as a physician, I know my limitations. And there's such a thing called multidisciplinary care. So make sure, as a patient and also as a caregiver, that if you can get into a clinic or into whether it's primary care or whether it's a neurologist, ask about social work. Or you shouldn't have to ask, but make sure if you're not offered it, ask if that's available, because you want to see if the patient has access to home health. If the patient has home health, use that time that a home health caregiver, it can be a home health nurse or a nurse's aide, use that time to take time for yourself. I tell all of my caregivers, make sure that you get sleep, make sure that you're exercise. And I know it sounds easier said than done because you're there constantly worrying about your patient. But one conversation I had this past Thursday with a patient of mine who's actually a caregiver for their spouse, I said, how can you be a good caregiver if you're not taking care of yourself? And she didn't think about that. And so I always encourage that. And I think the reason why I take that role as a caregiver seriously, because I was my mother's caregiver. I've been in that role. And I remember being so stressed out. And this was even before I became a doctor. But I remember her doctor telling me, go to the gym, eat, you have to eat. And he would call, when he'd call to talk to my mother, he would ask to speak to me just to see, was I eating? Was I taking care of myself? And so because I had that experience, I make sure as a physician now, I practice the same. My patients are my patients, but in the event they have caregivers, by extension, I have to look out for them as well. Other thing somebody in the chat asked about driving, that's part of the caregiver role. And one thing we learn as neurologists is we trust the caregiver. So if the caregiver comes and tells us, my loved one is getting lost, getting an accident, you got to take away the keys. And so you have to help, in some way try to provide transportation. In Lexington, we have the Wheels program that helps patients get back and forth. Ride sharing programs, sometimes some facilities might help offset the cost. So there are options, but these are things that we have to think about as physicians, like trying to help caregivers make their own lives easier, but also make sure that the patients are well taken care of. So I'm going to end with that. I'm sorry, I have to go. My patient's here.
I am so glad you were able to stay on with us for as long as you did.
Yeah.
I know your information has been in the chat. We will make sure to pass it along as well. Unless you have any objections, I will make a sticky note in our booth. Just leave it up there. It'll be up there all week. And if anybody wants to reach out to Dr. Ebon, share with her more, definitely if you're in that Lexington, Louisville area, follow her on Twitter. You've been amazing, and I know you got a patient waiting, so we will go. But thank you so much. Thank you so much.
Thank you so much, and everybody. Thank you all for the opportunity.
Thank you. So Dr. King, I'll come to you and same thing. I know Dr. Ebon laid out some amazing things, but you again, you're in this kind of clinical, also scientist space of asking these questions and wanting to get these answers for it. But in terms of that caregiver and including them in it, what are some things that you do or you would share with the group?
Sure. So it starts with the initial visit. So I have found that sometimes the patients want to come in by themselves, or they don't want family involved, or they feel embarrassed about that. And so I try very hard to include caregivers from the very beginning in the process. And in fact, many times I'll ask patients to come back with their caregiver, because I found that trying to take care of everything and do this is much more difficult if there's not a caregiver present. And then once we're in the room at the same time, there's always, we're often this fear of, I don't want to say something to upset my loved one while we're in the same room. And so I do things like tell both the caregiver and my patient, hey, I'm going to ask both of you for your perspective on what's going on. Like, I want to validate everybody's perspective, but also acknowledge that from the very beginning, you might have a different perspective than your loved one. And that's okay. And that's why we're here together, is trying to understand each other, where we're coming from, so that we can try to get on the same page. And I let the patients go first, because oftentimes if you don't do that, you'll find that their voice gets kind of muffled out in some way, or it gets covered up, or they don't get a chance to really say what they're feeling. And even though sometimes what they're feeling may not feel like it's accurate, understanding what they're saying and where it comes from, even if it's not correct in the detail, is still correct in their perspective, right? So you have to understand their perspective so that you could live in their world with them and help them to navigate that world. So, so absolutely trying to make sure that we're all on the same page from the beginning from a clinical point of view is critical, because a lot of the things that I will want to do require the caregiver to be in charge of it. So whether it be medications, whether it be getting exercise, whether it be just trying to establish a good sleep-wake cycle, these are things that have to be done together, and they're not easy. So giving caregivers sort of permission to take care of themselves is another huge part of this, because you kind of lose yourself in the process of caregiving if you're not careful. You can get so focused on taking care of your loved one that you don't take care of yourself. And Dr. Ebong said it, and I'll say it again, if you can't take care of yourself, it's much harder to take care of anybody else. So you have to be able to have that time for yourself. And that's something, so what I like to do is to try to expand the caregiving network as wide as possible. So this is like running a marathon. So you can try to sprint it yourself, but you're going to get tired, right? So the more people that we have that can carry that torch, the easier it is to reach the finish line together. So I want uncles, aunts, siblings, neighbors, church members, anybody who's willing to be a part of that caregiving network to be a part of it early. And that way you can try to reduce caregiver fatigue. You can't completely eliminate it, because caregiving is super difficult. But if I can minimize it, if I can give you a chance to take care of yourself, then it becomes easier for everybody to move along together. That does mean you have to delegate, and that can be quite tricky for some caregivers. I know they want to take care of everything themselves and make sure everything is perfect. I get that. Everything's not going to be perfect. You can't make everything perfect. It just has to be good enough, right? And so if you can delegate some time for somebody else just to take care of it, and yes, it may not be every single little thing that you would do, but they're going to be fine. They're going to get through it. And then you can come back refreshed and then take your position back and do what you need to do. So that's all a good thing. And there is a role, of course, for external resources. So everything from social work, so that you could create a power of attorney. So knowing who's going to be in charge when your loved one can't take care of things themselves. Knowing what your loved one's desires would be. So some people are fighters and want to fight to the end and do everything that they possibly can, lumbar punctures, investigational drugs, throw me under everything. I want to try everything, fight. That's great. But others are more like, you know what? I've lived a really good life and I've enjoyed what I've done, but I don't really want to go through a whole lot of invasive procedures, right? And so there's no right or wrong answer to that, but it is your loved one's answer. And so what we want to do is to respect the dignity and the desires of your loved one when you're setting up this plan, so that you can appropriately triage where to go next. And if you don't ask early, then you won't really know. So this is one of those questions I encourage families to ask right away. Like, what do you want me to do? You know, if you have trouble breathing, do you want me to put a tube in your mouth? Do you want to be put to a ventilator? You know, and if so, for how long? You know, these things. What would you want on there? And then just try to get a flavor for that. And these are answers that are not set in stone either. These things can change as situations change. So it's important to have these conversations multiple times to make sure, one, you'll know if there's a consistent answer every time, you know that they don't want this no matter what. Okay.
Absolutely.
There's a really good resource, if I could jump in, called
please.
5 Wishes, that walks families through the process of answering these questions in layman's terms. And it's really good. It's a little booklet that you can get. I think you can just download it online, 5 Wishes. And it's been really helpful. And if I could piggyback, I know we're running out of time.
Go ahead.
So as it goes to Alzheimer's, we're an advocacy organization. So this is an area that I think we really need people advocating, lobbying for caregiver rights. We've got over 60 million caregivers in the US, 60% of whom are working jobs, and they're not getting paid for their caregiver work. They're giving the US over 18 billion hours of unpaid care, not reimbursable through Medicare. People are losing their jobs because they need to take time off to spend with their loved one. They're having to change their schedules to be part-time. We've got millennials who are just coming out of college, being caregivers, not ever really fully entering the workforce. The US is the only industrialized nation in the world that does not have a national paid family leave policy. We passed 27 years ago family medical leave that provides employees who work for large employers, meaning people who have over 500 employees, the right to take time off without losing your job, and it's unpaid. So for some people that works, right? But we're now at a place where our aging of America is taking hold, where these dementia caregivers have an enormous burden that we need to be doing what we can to make it paid process. So we're supporting efforts in Congress. We've unfortunately seen that Congress is willing to do some paid leave, but only for people who are taking care of young children. And there certainly should not be a war between people who are taking care of young children and people who are taking care of adults. But that's the way politically it's being broken down. A bill was sent to President Trump that he signed into law that allowed federal employees to take time off with pay for the care of the birth and adoption of a young child. Caregivers were purposely excluded from that. Also, the COVID legislation that provided emergency care, again, caregivers were written in and then taken out. So please visit the Us Against Alzheimer's website. We are forming groups. We are lobbying for this because this is an area that economically could be really bankrupting for people who are just trying to do the right thing by their families.
Absolutely. And we have some of that. Again, we as an organization strongly support all of those efforts in terms of what we need to do to move the needle of policies. We know that if we can change policies, we can work on things such as the environments that individuals are in and some of the systems that people are touching, like healthcare, like research, that we can put the wraparound around caregivers and those who have diagnoses of cognitive health challenges in a much better way. So really quickly, and I know we're going to try to get to as many of the questions. I did, there was a really, really lovely comment, Dr. King, someone says you should write a book, or have you written a book? You really laid a lot of beautiful gems out there in terms of what we need to do, not just to support caregivers, but what we also need to make sure that we do as caregivers ourselves. So I wanted to just, in case you had missed that, that they suggested that you write a book. So in your spare time, you may want to add that to the list. I think I can see the question and answer. So I'll try and again to get through as many of these as we can. But if not, I will definitely take all of these questions and I will paste them into our exhibit booth chat with the question and provide an answer as best I can. I will also share these questions with our amazing panelists. And then if you can give them, because they're all busy, give them some time to be able to respond it. And what we can do is just to create a Q&A for this session, and we will add that to the on-demand again, and it'll be available for 365 days, but we will work to make sure that we can get these questions answered. So even if we don't get to them today or can't answer all of them in the booth, we will compile them, provide answers and expertise to them, and then make them available as a document within the conference site. So one person was asking, are there some healthy foods for brain or exercises that help to keep our brain healthy? And Stephanie, I know you mentioned a couple, if you just want to touch on that again.
If you can get, eat foods with low fat, that's very helpful. I just bought up my first oil-free fryer, and it worked really well. I was surprised. But, vegetables and good fruit. If you can, try to not get things in the can because they're loaded with sodium. Just some really basic things. And again, just put as much color on your plate, even if that means an apple or an orange. You can mix your fruits with your vegetables. It's okay. You just want some color. Carrots, you can make them up like sweet potatoes, maybe without all the sugar, but they taste very good too. So just try to, add a little something that's different. And the way we prepare foods is really going to be the key. Everything in moderation. That's my philosophy.
Perfect. There's another session, I believe, on Wednesday or Thursday as well, that we do have a panelist with a registered dietitian and some folks who will be talking about and adding to what Stephanie is saying about how, in moderation, but how do we switch up and make small incremental changes into our diet as well as our exercise. So just look out on the agenda for that. Dr. King, there was a question. I mean, I know you actually do some mentorship, but the question is asking what can be done to encourage more African-American physicians to kind of enter into these specialties that we need, whether it feels like yours or even like with Dr. Ebon.
Yeah, so it's a complicated question with multi-level answers. The biggest issue really involves some of the way in which the field is compensated. So right now, fields that do more procedures or that can do things that are kind of, I don't know, easier to quantify, like reading images, get paid more. And fields that do more conversation, like for me, it takes an hour to an hour and a half to really figure out what's going on with the patient and try to make a diagnosis, but you don't get compensated for that time. And so we have to, if we believe that this is important, then we have to put our money where our mouth is and say we want to pay people equivalent salary or an appropriate salary to do the work. You need to have people in the field to sort of mentors for others that are going into it, of course. And so that's an important role that I have, is to make sure that people know that there are others who are in the field who can blaze the path and create it. Because in many ways, I have the most interesting clinic on the planet. I mean, I see all kinds of the coolest things ever in my clinic. And so I'm very happy to have people come through and try it. And then making it where people are aware of the disparities that are happening and then sort of educating people about the needs that are out there. And we're getting better at that, but still a big unmet need that we have to approach people early. So you can't just wait till they're a senior in medical school and say, hey, here's this cool field, because then it's kind of too late. They've already picked, or cardiology or whatever field that they've seen. So we have to get them, high school, get them early in college and say, here are these fields, here are these interesting things that are happening. And so fortunately, there are things like a student interest group in neurology that are designed to help college students become more aware. There are opportunities for diversity that are opening up. So we are making strides, but it's not enough. We need to do more.
Absolutely. So I'm getting a message from our tech folks. They will kick us out even if we are still in here trying to chat. So thank you and good afternoon, everyone.